So hello everyone, our today's topic is the local anesthesia. So what are local anesthetics? They are the drugs that when applied on the skin or injected into specific area, they will temporarily block the feeling of pain in that area. So they work by stopping the nerve signals without harming them. So that means that they not only block the pain but also temporarily paralyze the muscle and affective functions. So coming to the introduction, in the ancient time, in the earliest pain relief we used was the coca shrub. It is native to the South America, particularly the Andes region. So apart from that, people chew coca leaves. So chewing the coca leaves would provide a mild numb effect in the mouth, so offering some local anesthesia for the dental pain. Similarly, the cocaine, it is a potent alkaloid that is derived from the coca leaves. Coming to the history of the Lignocaine, who first of all developed the anesthetic Lignocaine? It was Lofgren. So Lignocaine, Lofgren developed the anesthetic Lignocaine under the name Xylocaine. So let us discuss the first of all the indication for the use of Lignocaine in the dentistry. So first of all, local anesthetic, it is used when removing tooth, whether it is simple extraction or a complex surgical extraction. Fillings, for cavity fillings, local anesthesia is often applied to numb the area around the tooth being treated. In case with the root canal therapy, involving the removal of the damaged pulp from inside the tooth. While preparing crown and bridges, while performing gingival graft or periodontal scaling and root planing. Yes, for the implants, local anesthesia is used during the placement of dental implant. Specific other medical situations like tracheal intubation. So local anesthesia, it can be administered topically or through IV infusion to reduce the discomfort that is associated with the tracheal intubation. So Lignocaine used in the tracheal intubation is aimed at reducing the cardiovascular stress response to the procedure. Second, as we know that Lignocaine, it is anti-arrhythmic property. So that means that it can help to stabilize the irregular heartbeats in situations like cardiac arrhythmia, etc. So while local Lignocaine, it acts as a local anesthetic. It can also indirectly influence the cardiovascular parameter by reducing the body reaction to discomfort and stimulation associated with the procedure. So other indications, it can be used in orthodontic procedures, while adjusting braces, or in biopsy procedure. To diagnose oral lesion or abnormality, local anesthesia could be given to the biopsy site. Treatment of the temporomandibular joint. The injection local anesthesia may be used as an injection into the jaw joint to relieve the pain and muscle tension associated with the TMJ disorders. So all these are the indication for the local anesthesia. Let us discuss the difference between the local anesthesia and the general anesthesia. First of all, the local anesthesia, it is used to numb a restricted, that is a specific area of body, like a small section of skin or a localized area where procedure will take place. Whereas the general anesthesia, it includes a stage of unconsciousness and there will be complete lack of sensation throughout the entire or the whole body. The site of action of general anesthesia is the central nervous system, whereas local anesthesia affect on the peripheral nerves. In general anesthesia, the consciousness is lost, whereas in local, the consciousness is unaltered. Local anesthesia, it is a minor procedure, whereas GA, it is a major procedure. So in a non-cooperative patient, local anesthesia is not possible, whereas GA can be given. So all these are the differences between the local anesthesia and the general anesthesia. Let us discuss the classification of the local anesthesia. So we can classify the local anesthesia based upon the whether potency, low potency, intermediate potency or the high potency. Low potency, short duration acting are the procaine and chlorprocaine. Remember for your entrance exam. The intermediate potency are the lignocaine and prelocaine, whereas the high potency they are tetracaine, bupivacaine, ropivacaine, etetracaine, mepivacaine, dibucaine. Based on the classification of this, they can be classified either as a soluble or insoluble. Soluble are cocaine, lidocaine, tetracaine, and insoluble are benzocaine, butyl aminobenzate, etc. Based on the chemical classification, they can be classified as either ester or amide. The example of esters, they are butadiene, cocaine, benzocaine, piperacine, tetracaine. Esters are of benzoic acid or of para-aminobenzoic acid. The example of the para-aminobenzoic acid are chloropropane, procaine, propoxycaine. So remember the esters, they are metabolized in body through process known as hydrolysis. Whereas the amide, let us discuss the example of amide group first. The amides are articaine, bupivacaine, dibucaine, lidocaine, tidocaine, mepivacaine, prelocaine. So remember these amides, they are metabolized in the liver. Remember the esters, they are more prone to the allergic reaction. The para-aminobenzoic acid, it is a break product of the esters that can trigger allergic response in some individuals. Whereas amide, they are less likely to cause allergic reaction. So they are generally safer to use. So the choice of which type of anesthesia to use depends on the factor like the specific procedure, the patient medical history or any allergy or sensitivity. Suppose a patient enters to dental clinic and it is allergic to ester type local anesthesia. Which type of local anesthesia would you use? Here, if it is allergic to ester, then we will prefer the amide type local anesthesia. So when the patient has a known allergy or sensitivity to ester type local anesthesia, it is crucial to choose an alternative that is less likely to trigger an allergic response. So in such case, we will prefer amide type local anesthesia. The example being the lidocaine, bupivacaine. So the amide, they are generally safer because these amides, they are metabolized in liver, and that is why they are less likely to produce allergic reaction than esters, which are metabolized through hydrolysis. There was a question in exam: if a patient is allergic to both ester and amide, then which drug you will be using? In that, you can use diphenhydramine. Now, what are the natural local anesthesia? They can be saxitoxin or tetrodotoxin. So tetrodotoxin, it is found in various marine creatures. So mechanism of action is this tetrodotoxin will block the voltage gated sodium channels. So it will block these channels. So as it inhibits the influx of sodium that are essential for the propagation of nerve signal, so that results in loss of sensation and muscle paralysis in the affected area. Other is the saxitoxin. It is a product that is obtained from certain species of marine dinoflagellates. So it can accumulate in shellfish, making them toxic when consumed. So like the tetrodotoxin, it has the similar mode of action. So remember the point that all the LA, they are the weak bases. So all LA, they are weak bases. So what is the mode of action? First of all, you should know the normal nerve physiology. The neurons, they have a resting membrane potential that is around minus 70 millivolt. So that means that the inside of neuron, it is negatively charged compared to the outside. So this resting state, it is maintained by the permeability of cell membranes to ions and activity of the ion channels. Now, what is action potential? It is the action potential, it is the sequence of the events that consist of depolarization, repolarization, and hyperpolarization. So the action potential, it consists of, first is the depolarization, other is repolarization, and third is the hyperpolarization. Let us discuss them one by one. Depolarization. Depolarization, it is a process by which the neuron membrane potential become less negative. That is strong to open the sodium channels. So when the sodium channels will open, the sodium would run into the neurons. So due to the influx, the sodium, they are positively charged. So the influx of the positive ions reduces the negative that are present inside the cells. So making the membrane potential less negative. So if the depolarization reaches a critical threshold, typically around minus 55 millivolt, it will trigger the initiation of the action potential. So after depolarization, the neuron will undergo repolarization. So they will try to restore the negative charge inside the neuron. So the repolarization, it is achieved through opening of the potassium channels. So this repolarization is achieved by there will be opening of the potassium channels. So these will allow the potassium to leave the neuron, that restores the negative charge. So the repolarization will bring the membrane potential back to the resting state of around 70 millivolt. So if the stimulus, remember, does not reach the threshold of around minus 55, depolarization, here the process that depolarization would be insufficient to initiate a action potential. So if it is less than minus 55 volt, then the neuron would be in the resting state. So if the depolarization does not reach the threshold and action potential is not generated, preventing the transmission of the signal. Now let us discuss what is the mechanism of the lignocaine. The first step we discussed was the depolarization. So in the normal nerve cell, when stimulus that is stronger to initiate action potential, the sodium channels would flow into the neurons. That would cause a depolarization. Now what would be the suppose lignocaine is given. So remember, lignocaine is a sodium channel blocker. So what is lignocaine? It is a sodium channel blocker. So what lignocaine will do, it will enter the nerve cell and attach to this voltage gated sodium channel in its open or activated state. So when the lignocaine will attach to the sodium channel, it will hinder their ability to allow sodium to enter into the neuron. So this means that during depolarization, few sodium ions can flow through this blocked channel. So result would be the rate and extent of depolarization would be decreased. So the neuron struggles to reach the threshold necessary to generate an action potential, as the sodium influx would be hindered. Now, in repolarization, after the depolarization, the nerves undergo repolarization to restore the resting membrane potential. That again we discussed that here would be the opening of potassium channels, allowing potassium to leave the neuron and restoring the negative charge. So what would be the effect of the lignocaine here? As we know that lignocaine is a sodium channel blocker. It primarily affects the sodium channels and does not have a direct impact on any potassium channels. So when the lignocaine does not directly interfere with the repolarization, its action during depolarization can indirectly influence the subsequent repolarization process. So if the depolarization that would be inhibited or slowed down due to the lignocaine blocking the sodium channel, the effect on the repolarization may also occur more slowly. So it will extend the time it takes for the neurons to return to its resting state. So the lignocaine primary mode of action is to block sodium gated channel ions, slow down or inhibit the influx of sodium ions during the depolarization. So this interference with the depolarization indirectly affects the repolarization and makes it more difficult for the neurons to initiate and propagate the action potential. So resulting in temporary loss of the sensation and pain relief in the area due to which the area where lignocaine is applied. Now let us discuss the role of pH and pKa. So what is pH? pH is a measure of how the acidic or basic. So it is a measure of something acidic or basic. A scale from 0 is termed as very acidic and to term 14 value is very basic, whereas the 7 is known as a neutral. And pKa, it is the number that tells us how the molecule can change its shape and become charged or uncharged. So if pKa is very close to pH, of its environment, it is more likely to change. So it is more likely to change its shape. Now lignocaine, as we know that it is a molecule that we use for the pain relief. So it can change its shape either becoming charged or uncharged. That is like a magnet or not. Lignocaine pKa value is 7.7. So it means it can change its shape more easily in environment with pH when it is close to 7.7. So if pH is very close to 7.7, it can change its shape according to this statement. Now let us discuss how the lignocaine it would work in normal physiology. So when you get an injection of lignocaine in your body, so where the pH is slight acidic, that is a pH of 7.4. So if the pH is 7.4, this means that lignocaine is more likely to change it in the charge form. So this charge form can block the pain signal by interfering with the nerve cells communication. So the lignocaine effectiveness, it will depend upon its ability to change shape and become charged, and this will depend upon the pH of the environment. So in the slightly acidic tissue where pain signals occur, lignocaine is more likely to work well. So example, let us discuss why the lignocaine is not effective in situation like pus. You give a lignocaine infiltration or block, you find the patient still feels a pain sensation. Why that occurs? So in the acidic environment, that is, the pH will be a lower pH. So the lignocaine here will be having a harder time shifting into a charge blocking shape. It acts like a weak magnet. So the lower pH in the pus affects its ability to easily change. So that is why, due to presence of pus, the lignocaine may not be as effective as blocking the pain signal, as it struggled to become the blocking magnet due to the acidic pH. So in the pus, the lignocaine feel the difficulty shifting it into the charged form because of pH that does not match with the pKa value. So it is just like a magnet that is not sticking well to the material. The sensory and the motor fibers, they are equally sensitive to the local anesthesia. The small nerve fibers, they are more sensitive than the large nerve fibers. So the sensitivity to the local anesthesia, it is determined by the diameter of the nerve fibers as well as the fiber type. Remember, the myelinated nerve fibers, they are blocked before non-myelinated fibers of the same diameter. The smaller fibers, remember, they are more sensitive than the larger one. The smaller sensory fibers, they are more vulnerable to blockage because they generate high frequency, long lasting action potential as compared to the motor fibers. Now among the somatic afferent, the order of blockage is, remember the order: the pain, temperature, touch, proprioception, and skeletal muscle tone. So while giving lignocaine, you will notice that the pain is first blocked. So pain, it is often carried by the small diameter fibers, and it is the first modality to be affected. Some people might feel touch sensation but not pain while using local anesthesia because the pain will be the first modality to be affected, then temperature, then touch, then proprioceptor, and then skeletal muscle tone. And the recovery is in the reverse order. So the fibers that are more susceptible to local anesthesia, they are usually the first to be blocked and last to be recovered. So last to recover here would be the pain sensation. Now the taste perception. So when applied to the tongue, the taste sensation are affected. The bitter taste is lost first, followed by sweet and sour taste. So remember, the bitter taste is lost first, followed by sweet and sour taste, while the salty taste would be affected last. So as we know that the lignocaine, they are weak base, so their lipid solubility would allow them to penetrate the cell membrane. So which is composed of lipids. Once it gets enter into the cell, the local anesthesia can assess the intracellular component where it exerts its effect on the nerve fibers. The lipid-soluble local anesthetic tend to have a more rapid onset of action and longer duration of action, as they can easily penetrate the cell membrane and remain within the nerve fiber for an extended period. So more lipid-soluble local anesthetic will have more potency. Along with that, while the lipid-soluble is advantageous for the drug penetration, it can also increase the potential for systemic toxicity if the drug spreads beyond the intended site of action. Now, what are the ways through which local anesthesia would affect? So first of all, the mode of action is the local anesthesia. It raises the threshold potential required for an action potential to occur. So that means a stronger stimulus is needed to trigger an action potential in the nerve cells exposed to the drugs. The first principle was it altered the rafting membrane potential. So they do it by blocking the sodium channels in the inactive state. So by preventing these channels from reopening, they inhibit the influx of sodium ion that are responsible for depolarization. The third is they decrease the rate of depolarization by inhibiting the influx of sodium ions into the nerve cells. And last is they prolong the rate of repolarization. That is the process of returning the nerve cell's membrane to its rafting state after an action potential. What are the theories of the local anesthesia? There are various theories of local anesthesia. Let us discuss them one by one. The first is the acetylcholine theory. So that is related to neuromuscular transmission. It involves the release of acetylcholine at the neuromuscular junction and its action on the muscle cells. Second is the calcium displacement theory. The LA will cause nerve block by displacement of calcium from some membrane that controls the entry of sodium. Other is the surface charge theory. It acts by binding to the nerve membrane and changing its electric potential. Other is non-specific membrane expansion theory. Other is the non-specific membrane expansion theory. We know that LA, they are lipid soluble. They can enter the nerve membrane and change the configuration of the membrane. So therefore, by reduce space for the sodium to enter, and that causes inhibition. The next is the specific receptor theory. It is the most accepted theory. It is also known as lock and key model. So it was first of all given by Fisher. So according to this theory, the drug interact with the specific receptor as a key will fit into a lock. So each drug, it has a unique chemical structure that allows it to bind selectively to its target receptor. Next, coming to pharmacokinetics of the local anesthetics. So when local anesthesia, it is injected into the soft tissue, they can have pharmacological effects on the blood vessels. So they can produce vasodilation. Remember, many local anesthetics like Lignocaine produces vasodilation. when injected into the soft tissues. Vasodilation means the blood vessels in that area expand, leading to increase in the blood flow. So that can enhance the distribution of local anesthetic throughout the tissue and prolong its duration of action. In contrast, remember, cocaine is the only local anesthetic that can cause vasoconstriction. So vasoconstriction means narrowing of the blood vessels that will reduce the blood flow to the area. That can minimize bleeding and prolong the local anesthetic action. The cocaine, it has significant potential for abuse and it is not used for medical purposes. Now, what are the ways through which local anesthesia can be given? Oral route, topical route, or by injection. The oral route, it is less common and it is used for mucosal or dental procedures. Example is topical sprays, gels can be used. So topical oral gels or sprays containing lignocaine can be used. Second route is topical. Topical local anesthesia, it is applied directly to the skin or mucous membrane. Example is EMLA, cream that contains lignocaine and prilocaine. That is used to numb the skin before the procedure, like minor surgical incisions, etc. The third is the injection. It can be injected directly into or near the area where the procedure has to be performed, like lignocaine for the dental work to numb the mouth, bupivacaine for epidural anesthesia during childbirth, etc. Coming to the toxicity, the systemic toxicity of the lignocaine upon rapid intravenous injection is related to its anesthetic potency. The CNS effect includes effects include lightheadedness, dizziness, mental confusion, convulsions. The CVS toxicity may manifest as bradycardia, hypotension, arrhythmia. The local tissue toxicity of LA is generally low, but the wound healing may be delayed. Hypersensitivity reactions include there may be rashes, angioedema, asthma can occur with the lignocaine. So these reactions generally are more common with the ester-linked lignocaine. Ester-linked local anesthesia, but rare with the lignocaine. So let us discuss the explanation of distribution of lignocaine in various tissues. The first, blood. Lignocaine, it is highly soluble in blood, so that means it can quickly distribute through the circulatory system after the administration of lignocaine. So it binds to the plasma protein, particularly in the blood. It binds to the plasma protein, particularly the alpha-1 acid glycoprotein. Brain. Lignocaine can penetrate the blood-brain barrier to some extent. It doesn't accumulate in the brain because it has a relative short duration of action. Third, liver. It undergoes hepatic metabolism through cytochrome through cytochrome P450 enzyme that transfer it into various metabolites. Kidney, lignocaine, it is excreted from the body through the kidney. The kidney receive a substantial blood flow that contributes to presence of lignocaine in the organ. Now remember, the skeletal muscle has highest level because it has the largest mass of tissue in the body. So the skeletal muscle will have one of the highest level of lignocaine distribution in the body, as the skeletal muscle is well perfused with blood and it has a high capacity to bind to lignocaine. So this property make it ideal location for administering local anesthesia for the procedure involving the muscles or the surrounding tissues. Just remember that. Now the blood level of local anesthesia, it is influenced by the rate at which the drug is absorbed in the CVS. That means how quickly the local anesthesia get into your bloodstream after you have received it, like through an injection or a cream on your skin. If it is absorbed quickly, it starts working faster. Second, the rate of distribution from the vascular compartment to the tissues. So that refers to how your body gets rid of local anesthesia when it's done its job. So the main way is through the kidneys. So when you pee, so when your body can get rid of efficiently, it won't remain in system too long. And third is elimination of the drug through excretory pathway. Already explained that mechanism. The second, the rate of distribution from the vascular compartment to tissues. That means how fast the local anesthesia spread from your blood into different parts of body, like the muscles or organs. If it spread quickly, then it can affect those areas faster. Now let us discuss what is half-life, elimination half-life. The lignocaine, it has an elimination half-life of around 1.5 to 2 hours. That means it takes approximately this amount of time for half of the administered dose to be metabolized and eliminated from the body. So remember, the lignocaine, it can cross the blood-brain barrier and the placenta. So the lignocaine, it can cross the placenta. That means it can reach the developing fetus if it is given to the pregnant individual. So the lignocaine during pregnancy, it should be used with caution, as it to minimize the potential effect on the fetus. The next comes the metabolism, that we discussed it earlier too. The ester type local anesthetics, they are hydrolyzed into plasma, that is the liquid portion of blood, by the enzyme that is plasma esterase, that is acetylcholinesterase. So the hydrolysis process convert them into inactive metabolites. That metabolites are excreted by the kidney as water-soluble compounds in the form of urine. The amide, the amide types, their primary site of metabolism is liver. Now the excretion, the major source of excretion is the kidney. The esters are completely hydrolyzed in plasma. In the patient with the impaired kidney, remember, these clearance of these metabolites can be compromised. So that can lead to buildup of metabolites in the bloodstream that can increase the risk of toxicity. Now, what is the composition of local anesthesia? The first is the local anesthetic drug agent that can be ester type local anesthesia or amide type, like the lignocaine. The ester types are procaine, chlorprocaine, amide are the lidocaine, bupivacaine, ropicaine. The second is the additive, is the adrenaline. So this is the vasoconstriction. It helps to reduce the bleeding at site of injection and improve the duration of anesthesia by slowing the absorption of local anesthetic. The third is the sodium metabolite. It is a reducing agent. The sodium metabisulfite is used as an antioxidant. So it is used as an antioxidant by reducing the oxidation potential of local anesthetic solution. So that will help the degradation of active ingredient over time, extended their shelf life. The preservative is methylparaben and sodium chloride as an isotonic solution. Apart from that, fungicidal like thymol, vehicle agent like Ringer solution, diluting agent to adjust the pH, sodium hydroxide, all these are added. Sometimes nitrogen bubbles could be seen. They are generally of 1 to 2 in diameter, and it is present to prevent oxygen from getting trapped in. Now let us discuss some individual agents. The first is the lignocaine. The lignocaine was introduced in the year 1948. The most commonly used local anesthetic is lignocaine. So when injected around the nerve, lignocaine blocks the nerve conduction within 3 minutes. That is faster than the procaine, which takes around 15 minutes. So lignocaine, it can cause vasodilation in the area when it is injected. So various use are, it can be used for surface application, infiltration, nerve blocks, epidural anesthesia, spinal anesthesia, and regional block anesthesia. Lignocaine could have early effects like drowsiness, mental crowding, altered taste, tinnitus. The overdose can lead to muscle twitching, convulsions, cardiac arrhythmia, etc. Respiratory arrest can occur due to the overdose. Also, lignocaine is a common antiarrhythmic medication. That is, it is used to treat the irregular heart rhythms. Now what is the dosage? The lignocaine with the adrenaline, it is used as a common concentration of 1% lignocaine with 1:1 lakh concentration adrenaline. So the recommended dose with adrenaline it is 4.4 to 7 milligram per kg of body weight. So the maximum is 500 milligram for the adults. And the lignocaine without adrenaline, the dosage is 4.4. The maximum dosage for the adult is 300 milligram. Now what are the effects of lignocaine? The lignocaine will first cause CNS stimulation. So that can be manifested as symptoms like drowsiness, mental crowding, dysphoria, altered taste, perception. And after the initial stimulation, the lignocaine has a depressant effect on CNS. So there can be drowsiness, mental clouding, and respiratory arrest if overdose can be given. If overdose is given, it could lead to respiratory arrest or cardiac arrest. It can also affect the heart. As we know, it is an antiarrhythmic medication to treat irregular heart rhythms, but in the overdose, it can lead to cardiac arrhythmia, which can be life-threatening. The next comes the bupivacaine. Bupivacaine, it is known for its long-lasting effect as local anesthetics. It is used as an infiltration, nerve blocks, epidural, spinal anesthesia, providing a long-term pain relief. So where it is used? Remember, it is used as an obstructive and post-operative pain. So it can be used in the vaginal delivery and post-operative pain through the epidural infusion. It has a high risk of prolonging the QT interval, and therefore it can induce ventricular tachycardia. Or depression. Bupivacaine, it can be used in the full mouth reconstructions, extensive periodontal surgeries where the prolonged anesthesia is needed, lasting between 90 to 180 minutes. So it is commonly chosen for the long-lasting pain. However, burning sensation at the site of injection that could be seen due to the injection of the bupivacaine. It is transient and tends to subside. Other is procaine. Procaine forms a poorly soluble salt with the benzyl penicillin. So this combination is used as procaine penicillin for treatment of the certain infections.